It's a pleasure to be here with you guys and to share a little bit about my own journey in artificial intelligence, which has been nothing less than mind-blowing over the past year. I'm a little bit of a unique guy. I've got background in engineering and in medicine and in public health. I've worked in the startup world, and so you can think of me as some sort of physician, entrepreneur, innovator, spiritual guy that's been on a mission my whole life to figure out how to take care of people and do a really good job for them. And it's taken me on a journey of finding ways to apply technology to solve that problem. And it's probably, 20 years that I've been on this mission. Most commonly known for Find My iPhone. That was my invention. And
Who uses Find My iPhone? I use it all the time. So thank you, Ravi. Thank you for inventing that. Yeah.
Yeah, I know. I was a medical student,
Yeah.
and someone stole my laptop, and I got really annoyed, and I was like, oh my God, why is there not software that allows me to find out who took it and secure the data? And this was 2000, at the dawn of the first .com era.
Yeah.
And I made the solution, built the company, patented the technology, and eventually my journey took me back to medicine. I fell into my own depression, and I reincarnated myself as a psychiatrist, but with an intention that one day I was going to figure out how to scale, automate, and replicate mental healing for everyone. And it also launched me on a deep spiritual journey to understand that root, because that's such a big part of mental wellness. And so I've done a lot of interesting things in my career, and I think even back then I had this vision, right? What if the computers could know everything about us?
Yeah.
What if they understood more than we understood? What if they also knew all the information and things that we needed in order to help us? How could that change the needle? And we built a lot of the tools around data collection so that you could figure out with sophisticated forms and interview process what's going on with a person and get that information in. And I focused my early career on displaying that information to doctors in a way that was really useful. It would be intuitive. You just sit in front of your doctor and all of a sudden they know all sorts of stuff about you, instead of the appointment being spent sitting there collecting the data, pumping them for information. And that was one of the ills of psychiatry, as I saw. 1 hour to get to know a person, figure it out. 40 minutes is spent collecting information, and then 5 minutes is spent telling them what's wrong with them. 5 minutes is spent giving them a prescription. 5 minutes is spent giving an appointment, and off they go. And so I wanted to move that needle, and had great success in my work at Kaiser Permanente at building a new way of interviewing people with computers and presenting that information to doctors up front. What was missing, though, was the computers actually being able to take that information and be intelligent about it and do a lot of the work and do a lot of the assisting. And that all changed with the birth of ChatGPT, probably, November of last year?
Yeah, November 2020. And a lot of the dreams actually came true over the last couple weeks, where all of a sudden we did see this happen, right?
Yeah.
Yeah. So Ravi's been behind the scenes engineering something that we actually launched here at Texas Center for Lifestyle Medicine, where me and him were just blown away at what actually happened. But let's tell him about the first 3 patients that we onboarded. We're 3 for 3 right now, so let's tell him about the first 3 patients. Yeah, yeah.
Let's see. The idea is that the computers collect the information from the patient, right? So the idea is Cheng here has a pretty large primary care practice and a very substantial percentage. What percentage of your practice is mental health concerns?
It's about 82%, because we see all chronic diseases. We don't see acute diseases at all. All we see are chronic diseases, yeah.
Yeah, and it's also this not too often spoken about secret that the heart of chronic disease is mental health. Mm-hmm. You got to think about the diabetic who's depressed, mm-hmm. who wakes up in the morning and takes a pint of ice cream and shows up in the hospital later on in the evening. And so to actually move the needle in chronic disease management, you've got to treat the depression and anxiety in that population.
Yeah.
So the idea that I had is, why not go to primary care where most of these patients are? Very few. Only about 20% of people ever make it to a psychiatrist or a therapist, largely because of stigma, because of lack of supply. but there's very few psychiatrists out there compared to what the need is. And why can't we go to primary care and partner with our PCPs and give them a hand? They're taking care of 80% of the problem. And that's exactly what I did this year. I was building a company called Intuitive Mental Health. Intuitive because we know what's going on all the time. And and our treatment solutions and our approach to treatment is pretty refreshingly obvious and not esoteric and integrative and holistic, as well as grounded in evidence-based medicine. And so Cheng was my first customer, and we gave it a launch, 2 weeks ago, right before the holidays?
3 weeks ago, yeah.
Yeah, 3 weeks ago.
And the biggest aha moment that I had, because we both had an idea of what this can do. But the biggest aha moment is that in the first 3 patients, the significant things were found. And Ravi messaged me, he was like, hey, you're supposed to give us some easy patients when you first on board.
Yeah.
But this person is basically in crisis. Now, this person came into the clinic and she was very joyful, okay? She's very calm, very collected, smiling, okay? And now she did score high on the PHQ score, and so we're like, all right, easy patient, let's get on board and see what we can do. And this turned out to be a crisis patient, right?
Yeah.
Now, that's
It
weird.
was patient number 1.
That's patient number 1. And patient number 1, we got her into intensive outpatient therapies and make sure we got her with psych, and we gave her resources for behavioral hospitals, multiple in Houston. We were able to set that up. And I think that's within, 2 hours, 3 hours of onboarding or something like that, we were able to tease that out.
So that was fascinating. So the patient number 1 was a young woman who Cheng told me was an easy case. I told him for our first 3 or 4, give me easy cases.
I thought she was.
So we can make sure everything's working. And so we do our intake process on this patient, which happens within a few hours of his referral. And our AI-based triage model tells our medical assistant who reached out to her, hey, go get the psychiatrist immediately, urgent intervention required. And so I take a look at the output from the AI-based intake and review the data. Here's a woman with a psychotic disorder who's acutely suicidal. And I get Cheng on the phone. I was like, do you know what's going on here? What's the story? And as we looked at it, you could see the history of a woman who wouldn't endorse those things to a doctor. She wouldn't say it, but she was more than happy to let technology know, yes, I'm hearing voices. Yes, I want to kill myself. Yes, it's really bad. And so we were able to, within a matter of hours, start placing her and get her located and get her resources. And I understand she's doing a little bit better now.
Yeah.
But the point was that didn't even take a clinician to see the patient.
Yeah.
That was just done at the front door before they were even let into our system. And so
Right.
you can imagine the impact that would make.
Yeah, virtual front doors. It's all done virtually, so it's not an actual front door.
Right?
But one of the things that we always pride ourselves in is we spend a lot of time with the patients. Our new patient visits are an hour long, and we actually go through a lot of mental health and stress. And even with that type of intake, we didn't really catch that at all, right? And our follow-ups are 30 minutes long. So once again, we have an AI algorithm that lets us also understand what the intake should be. But yet we didn't really figure that part either. So that challenged a belief system that I had, is that the only way you can really identify mental health challenges was with a qualified mental health practitioner. But that's not what we found whatsoever. And then patient number 2 came along.
Yes.
You want to talk about patient number 2?
Yeah. Patient number 2 was a 30-something-year-old, she was number 3. Number 2 was the guy.
Yeah, the gentleman, yeah.
Yeah, the gentleman. 50-year-old gentleman with a history of depression, treatment refractory depression. It's never getting better, and a lot of fatigue. And he was on an antidepressant, Wellbutrin, and so he was coming in for evaluation. We collected a lot of data at the front door, as we usually do. This is something that I got really good with over my career, and we're able to get some 400 data points about a person's comprehensive mental history in a matter of 15 minutes flat, with minimal pain on the patient's side. And that data was presented to an AI model that looked at it and identified a few interesting facts. First of all, he was complaining that he wasn't feeling restored when he woke up. He was always fatigued all day. And that he also was complaining of snoring. And that he also was taking 5 to 6 cups of coffee daily. And it made the suggestion that maybe this guy has obstructive sleep apnea that's inadequately treated or not treated, and he's fatigued all day and consequently drinking a lot of coffee in order to stay awake, which is amping him up with anxiety and leading to a really frustrating cycle. And it called attention to our clinician to make sure that gets addressed. And then the second point it brought up is the man is complaining of seizure disorder and is on multiple anticonvulsant medications to control it, and is on Wellbutrin, which is directly contraindicated because it reduces the seizure threshold and it can cause seizures. And he's sleep deprived chronically, and he's taking coffee. So does he really have a seizure disorder, or is it just the combination of all of these things triggering it? And how bad is the problem? And that was...
And this is the AI uncovering this.
Yes.
Not even within a clinician visit, right? And so you see the impact of this is extraordinary. Yeah.
Yes. And so this brings me to my point, that there's an era of medicine and healthcare that's based on root cause medicine, of actually figuring out what's going on, which plays to functional medicine, right?
Yeah.
And all of these things. But there's never enough time to collect all the data required in order to actually figure it out and sort out the situation and heal them. And allopathy, conventional medicine, has gone the route of symptom management and chronic disease management as a consequence. But I have this huge faith that we're moving into an era where we can actually get a lot of data, manipulate it, understand it, process it, and figure out what to do with people so we can actually heal them. So in this guy's case, we were able to find the root causes, and he actually has a shot at having a really nice balance of his life if we can just get his sleep apnea treated. And so this was all confirmed in his interview with one of our health coaches, that with AI prompting was able to know exactly what to ask, collected all the information for us to evaluate along with the AI models to know, and confirmed it. Yeah, that's exactly the situation that's going on. It's been going on a long time. And he knows he has sleep apnea. He doesn't like the machine. And he just didn't know the price he was paying as a consequence.
Mm-hmm. Absolutely. And for me, and all this, none of this is surprising, but what I was surprised is that the AI was able to pick up medication contraindications looking at the patient history. And he had a TBI-induced seizure, actually, which Wellbutrin is really contraindicated, especially with traumatic brain injury. As well as that's not something like I even picked up when I saw the patient. And I really had to go back into the books. I was like, oh yeah, you know what? He is on Wellbutrin. The AI is right, my friend. The AI is right. We're able to address it on the back end. But I think that after that intake, he's more convinced to get his sleep apnea treated than anything else. So you do have this patient-facing understanding of the consequences of things that can happen, which allows us to practice medicine at the top of our game, right? It makes everyone's lives easier. The medical assistants like this, the administrator, scheduling, right? You're not going to have patients that don't show up as often. I think that's extraordinary. And then patient number 3. Let's talk about patient number 3. They're all very different cases. Yeah.
Can you tell us about patient number 3?
Oh, patient number 3. So patient number 3 is one of those people that has this can-do attitude. Okay.
She looks so happy.
She looks so happy, and in fact, she comes here, she works with a mind-body medicine coach, the Tai Chi meditation, mindfulness, breath work. We do all the holistic stuff. But what's interesting is that there was a dark hidden side that's behind there that none of us knew about. So, what did you think when you saw her intake?
Yeah, she was coming to us with anxiety as her chief complaint on referral, right? Mm-hmm. And we found out that she was suffering with domestic violence. She was getting beaten up routinely at home and suffering. And she felt like she couldn't tell anyone, or that no one would care. And this was something that happened early in my career at Kaiser Permanente.
Yeah.
I missed a case of domestic violence, and a woman ended up in the emergency room, and it hit me at my core. Oh my God, like I should have asked. I didn't ask. And it's one of those things where if you don't ask, no one will tell. It's hard enough to even work it up to tell someone, and if you don't feel like someone wants to know, you won't know. And back in those days, I looked at the sobering statistic. Our Department of Psychiatry was only picking up 4% of the expected number of domestic violence cases that were in the population. And so I quickly went and modified my intake process for our department to comprehensively screen for domestic violence in the best possible way that would elicit the most favorable responses, to make it as easy for a woman to say yes if they're suffering, and then to offload the burden off the clinician. So if someone said yes, social workers waiting outside of the office door paged automatically to take it from there. And so the burden on the clinician, they don't have time, they don't know how to deal with these things, is removed. And the detection rate went up to 84% in 6 months, just like that, boom. And this intake technology, I was able to screen for it, which is amazing. And we were able to figure out that was her problem. And it wasn't anxiety, it was post-traumatic stress disorder. The trauma that she was enduring on an ongoing basis of having to be at home and being terrified of what's going to happen, the hypervigilance and the nightmares. And we were able to make recommendations to Dr. Ron here to treat that properly with appropriate medication, and for her to get referred to psychotherapists to work with her and to assess how we could protect her.
So that case was fascinating to me, is because in retrospect, knowing this and understanding that, she was using us as a safe place, like this practice as a safe place. She was literally doing Tai Chi here as a safe place, right? But we didn't recognize really why. And it's because we didn't specifically ask about the certain things, right? And it's because as humans, we tend to receive the energy of the other person. Of the energy of the person is, I'm so glad to be here. Thank you all for what you do. Like, you guys are amazing practice. I mean, that's the energy that we receive. It's like, oh, awesome, right? And but the perception is flawed in the end, because we didn't really recognize to even ask that, nor did we even think about to prompt to ask that. And here's what's even more interesting. She recognized that she actually has PTSD, because that was documented on the first entry in, but it has nothing to do with domestic violence. It had to do more with some childhood stuff. So we were actually working with her on childhood PTSD, right? But that created this tunnel vision for us. We didn't really ask for what's going on a daily basis here. And so, yes, we were working with the PTSD, and she was doing well with doing exercise, diet training, Tai Chi, Qigong. But my gosh, we didn't think to ask about safety. Now, Medicare, on Medicare wellnesses, you have a whole script. Do you feel safe at home? Do you have accessibility? But for someone who's much younger, you don't really have that as an algorithmic process, right? And now we're 3 for 3, right? Sure. The first 3 patients on board were like, whoa, okay, we're 3 for 3. And this is 2 weeks ago, y'all. But I got Ravi here and wanted to talk to him about it, because this is really impactful for both of us. We're very spiritual guys. And for us to miss something like this is not relevant when you have AI as part of the technology that can make us more human, make the patients a lot more human as well. Does that make sense? Any comments or questions on that real quick? What do you think about that? Yeah. Yeah.
I think for a couple of the cases you highlighted how the system can identify potential drug-to-disease interaction, but that's something that probably some medical records already have in place or pharmacy. So where can AI do better than we have already established, right?
Yeah, so I think just repeating because the camera's on. So the question is that, so on the intake process, you were saying that there's medical records or pharmacies that are able to already address this. How can AI do it better? Is that the question? What do you think?
Yeah, clearly.
Yeah.
Clearly. Because the problem with the human process is, like, if you take the typical physician, you're running back and forth between exam rooms all day long, and you have 6 to 7 minute appointments. They keep cutting payments, and the only response is to shorten visit times. And it's gotten a little bit ridiculous in modern times, unless you're really smart about how you practice. So then you're running with a waiting room backing up to the next patient, and then you're dashing in there, and you should have had 10 minutes to review the medical record to understand what's going on with this patient. What do I need to know? What do I need to do for them? And it might have been nice for someone to collect information in advance of like, why are you here? What is it that you want from this appointment today? And for that all to be assimilated by the doctor before they see the patient, and then when they're seeing the patient, to sit there and connect, to look, to make them feel safe, to allow them the space to tell us what's going on with them, and then document afterwards. But what happens now is, and this is a statistic, the average doctor spends 40% of their time in front of the computer screen. Our ECW guy here knows all about that.
He concurs. Yeah.
Right? And in one of my earlier presentations when I was building out some of these tools at Kaiser Permanente, I had a slide that showed a cartoon depiction that a 3-year-old, no, I think a 5 or 6-year-old child wrote, showing a picture of his doctor's appointment. And it showed a crayon drawing of the doctor's back to him and the doctor looking at the monitor. That was the memory that the child had from that appointment, right? And then I showed another slide called The Doctor. It's one of the famous pictures of all time. I think it's an 1800s oil canvas painting. And it shows a sick patient, the family standing around, and the doctor kneeling before the patient with eye contact, frozen in concentration and trying to understand what's going on here and what they need to do. And it was just like sobering to understand how far we've come as a healing profession to those points. And this has been paired with an explosion in the amount of data that's available on each patient, right? Hundreds and hundreds of pages and lab tests and studies and correspondences from other doctors and inputs from every direction, combined with an explosion of knowledge in medicine. Like my father is a physician. And he told me when he was studying medical school in the 60s, there was like 2 drugs. There was like a sulfa antibiotic and one other thing. And then they were just figuring out DNA back then. And they still had 4 years to learn everything that they needed to learn. And it was hard for them. It was really hard, okay? Now you can imagine what we're dealing with in modern times. And you have 6 minutes. So then the question is, do you think that doctor is able to actually understand everything that needs to be understood, or are they reacting to just the immediate question? Blood pressure high? Raise the med? Next visit. Next. And it's all well-meaning that brought us here. And for docs like Cheng and I, we look at AI as our hope and salvation to bring humanity back to the profession, to bring quality back to the profession, to bring the ability to take care of people and have these AI tools superpower us and leverage us up and allow us to command the information and be presented to and like to speak what needs to be done and have it get done. And yeah.
And the other part to it is you were talking about there's pharmacy fail-safe drug interactions and stuff like that, right? But the problem is there's desensitization, meaning that so many contraindications and things pop up all the time. You just hit skip, moderate to severe, sure, skip, whatever, right? And so that becomes, that happens all the time. So it becomes like super complacent. I try to prescribe cholecalciferol, which is vitamin D3. It had a major contraindication with most of the patient's seizure medications. I'm like, it's vitamin D, man. And so you get really desensitized by that, and when you hit skip, and then the pharmacy also get desensitized by that as well, right? But here's the thing. A lot of practicing medicine has been cross-sectional and transactional. What I mean by that, cross-sectional means that the patient comes in with some sort of complaint at that cross-section in time, okay? And then they come in and it's a transaction, a prescription, a surgery, some sort of therapy that's right there, right? So what AI allows you to do is not to be cross-sectional. It can look at the entire person's life. It can look at the parent's life, right? I'll give you an example. So I had a person that came in and was on three different types of antidepressants coming in, right? And one of the things that the AI picked up is that, hey, perhaps this person may be depressed because the folate level was 1.8 in LabCorp 3 years ago on the analysis. I'm not going to go back to all those pages 3 years ago to look at the actual folate level. And so we repeated, it was still just as low. And after supplementing with literally methylfolate, which you can prescribe, no longer transactional. It becomes, hey, let's get a high definition look at what's going on. And lo and behold, patients' mental health got significantly better. Fatigue got significantly better. Peripheral neuropathy went away, okay? And so we're talking about some big deals that are here that we're actually missing from minute amounts of data. And just like another example I have is that we had another intake, okay? And she was going through depression and et cetera. And the AI pointed, hey, person's ferritin level was 1 with anemia and iron deficiency. Perhaps you could look at that as a fundamental element of mental health. Is iron deficiency anemia associated with mental health issues? Absolutely, right? She had numbness and tingling, diagnosis of also peripheral neuropathy, has restless leg syndrome on the sleep study. Well, what's the major cause of restless leg syndrome? Iron deficiency as well. The AI was able to pick up all of that by looking at all the old records, okay? Doing it a few seconds, all right? Not a few hours, not a few minutes, not a day, a few seconds, and provide that. And if you use that amount of data, it no longer becomes cross-section, it becomes a high-def look. It's like a high-definition movie, right? And for us to do that as physicians, we have to charge about $2,000 an hour, right? Because like I said, I have another patient that we have the 200 pages of the hospitalization data can only be consumed if I sit there, go through discharge summaries and stuff like that, right? But the AI is able to give me a chart of the patient's hemoglobin and blood pressure, right? And also highlight some areas that I should be looking at as well. But what does that really do for us, right? Because innately, we have the knowledge to make decisions, but the quality of our decisions is literally based on the quality of the actual intake, the data that we have, right? So I do think that AI can play a very big role. And of course, the biggest thing is you get to look your patients in the eye. And George, you use the AI scribe, the getfree.ai, right? And I use Ambience. And literally, I'll set my phone or laptop here, and it's listening to me and the patients. I'm this close to the patient looking in the eye and talking. And most of what I do is neuropsych, so I really like to connect with the patients, right? And really have an amazing bond. It actually brings the practice of medicine, elevates it. And we have multiple clinicians within our organization. None of us remember what it was like to practice medicine without AI anymore, nor do we ever want to go back. Talk about decreasing burnout, yeah. And not only that, our number of messages from the patients went down 60% within 3 weeks of us using AI. Why? Because the AI is providing patient-understood summaries of the actual visit. It's providing it to the family. It's providing it to other healthcare professionals. If I say I'm going to refer you to physical therapy, it automatically creates a consult note, okay? Take some notes, ECW. I will love that if you all have it. If I say I'm going to refer you to a cardiologist, boom, picks it up within the conversation. Here's cardiologist, right? So say I'm going to prescribe this medicine at this dose, it puts it in there. I'm also going to prescribe some vitamin D, some ashwagandha, some L-methylfolate for you, some L-theanine to help you make you feel better at any time. Here's some melatonin, it puts all that stuff in there, right? And it gives a summary. We discussed this, and then we discussed this bulleted form. Okay, are you happy with this, or do you need more description? The patient can say, I want more description. It'll put up an entire paragraph of what we actually talk about. Think about how much less of a burden it is for the patients because they have this understanding, okay? And on top of that, all the medical assistants knew exactly what we were doing in each of the medical visits, right? And now, I'm really guilty of writing terrible notes, especially when it was back on paper, right? It's scribble no one can understand.
Your handwriting got even worse over these.
Yeah. When I became a doctor, my handwriting automatically got worse. And so I think, if you think about it, it's the master communication tool. It also empowers patients, and patients love those summaries. They can log into Hilo, which is the eClinical Works in the back end, look at the visit summaries, and then boom, export it, hand it to their doctors. And the doctors know exactly. If they're seeing cardiologists, they know exactly why they're being sent, right? And not on top of that, what about paperwork? Okay. See, I'm getting too excited. Where? In here? Okay. What about paperwork? Who likes disability paperwork? Anybody? No? Okay. We love it. You know why we love it? Because we just open up a chart, talk to the AI, sip on a latte, and have it fill it out, right? And because AI already is trained on what a disability paperwork looks like from Sedgwick, from New York Life, right? It's already trained on that, and it kind of populates in for us, right? And then guess what? We get to bill for it. If it takes you a while, okay, cool. 99358, all right, non-face-to-face contact with the patient, going over paperwork and stuff like that, right? Maybe you call the patient. Maybe it's a Medicare patient, G2251. Here, 5 minutes, I just wanted to let you know I did the disability paperwork. Okay, cool, thanks, awesome. Hang up, all right? Or maybe it's a secure message, right? 99421, secure message, 5 to 10 minutes spent on secure message per week, okay? How do I know all of these codes? Because the AI taught me, okay? Now, a lot of these codes were new in 2021. How many of y'all keep up-to-date CPT codes? Not me. Guess what? I programmed the AI to learn 2024 codes, so I inquire the engine, because I already learned all the AMA outputs for the 2024 codes, and I know, hey, Robbie, how do we bill for collaborative care management codes, COCM codes, 990, what is it?
99492.
99492, et cetera, et cetera. And so what it allows me to do is to build a business based on communication, based on excellent quality of care. And guess what? The AMA is not happy because they've made these codes and people aren't using it. You know what is the series of codes that everyone's really pissed about and no one's using?
Which one?
Interprofessional communication, okay? I'll text George, me and you have a collaborator on a patient. I'll text them, we'll talk for 5 minutes. How many of y'all bill for that? No? Yeah, there's interprofessional codes. In fact, if I write a note to you, I can bill for that note as well. So there's a huge fundamental CPT gap, and people think, oh my gosh, the cost of medicine is going up. No, the billing is just really suboptimal, right? If you think about it, we're Texas Center for Lifestyle Medicine here. We're not concierge. We're the traditional insurance model. How the hell do we get away with 1-hour visits on new patients and 30 minutes on follow-ups? And how do we scale from that? It's because we understand that the actual communication administration has a value that's assigned to it. And when you put that as a KPI, a key performance index, right, KPI, then you can actually develop an entire program based on that. So when Ravi and for Intuitive Mental Health came in, we have these CPT codes, right? I can build an entire KPI and outcomes on exactly what these actually reimburse, right? So from a practice administrator point of view, Tom, that's a big deal. Because I bet you your doctors are literally spending time and not building for it. That's exactly what's happening right now, right? Guarantee, yeah, exactly. But there's ways to do all this. When I wrote my book, and for those of y'all, I don't know what my book is, my daughter has my book somewhere. When I wrote my book, The Doctor's Guide to Thriving Integrative Medicine, Secrets to a Successful Practice Without Burnout, when I wrote that book, this was before ChatGPT, this is before AI, right? And now it just looks really outdated because of the AI. And that was published earlier in 2023. Actually, almost exactly a year ago it was published. And so when I wrote the book, there's a huge chapter on understanding CPT codes. And I'm like, you know what, here's the resources, go to the AMA, here's the AMA CPT editorial knowledge base, you can subscribe to that. If I wrote that book over again, I'm like, no, here's a QR code to my GPT engine I just built for you, have at a Haas. It becomes so outdated now, but if you think about it, all knowledge can become a knowledge base. And all knowledge base can be built into the artificial intelligence. Does that make sense? Yeah, these guys cursing. I wish my doctors were billing out a whole lot more, right? But I'm going to teach you what that is tomorrow.
I think it's another important aspect of this to just slow down and think about for a second is November 2022.
Yeah.
ChatGPT released, right? I was on it. I used it within the first 2 weeks, and I understood its potential. But it was stupid ChatGPT back then, right? They were just figuring it out, and the models weren't that sophisticated. But the potential was there. But we go from that experiment to it being on the clinical service line. ECW wanted to put in $200 million to go marry Microsoft, all within a year. And like us talking about it, how this is going to transform healthcare. That is mind-blowing. Can I use a whiteboard to show a little diagram?
Actually, you just got to pull it towards the center.
I thought about this like philosophically for a while. And if you kind of look at a chart here. And this is the time. And this is the rate of tech evolution. And if we say that, you know what, Renaissance period, 1400s, is a good starting place. We can say like right here, 1400, Leonardo da Vinci, right? And then this is at 2022, and this is 23, and this is where we are. Like, that's even being generous with the scale if we're talking about this many years, right? And I would suggest that the rate of human technological advancement has been like this, right? Something happened around here. We got a smartphone. That's cool, right? and we got an internet. But we're like this right now. And so you can imagine a human standing right here looking out. Everything kind of looks normal, like right here. Just kind of looks like things are normal. But the price of intelligence just went to zero, or the price of electricity. And the guy, Sam Altman, the guy who was the CEO, was, then became back, and is currently the CEO of OpenAI. He's got 500 million of his own cash in a startup that's called Helion, that's going to do cold fusion. And you know what's cool about Helion? The researchers are AIs. Mm-hmm. And they're figuring it out. And Microsoft already agreed to buy cold fusion energy from him in 2028 to power their AI cloud. So then, if you look at a world, and it looks actually promising, like they might actually pull this off, which is even more unbelievable. So if you think about a world where the price of intelligence goes to zero along with the price of renewable, unlimited, free energy, whoa, what just happened there? And I'm just suggesting we're ahead of the curve in this room, okay? It just looks normal out there, but something just changed. We have hit a singularity in the history of humanity. And there's no other way to look at this. If you use your intellect and actually understand what happened, it's a little bit unbelievable. Someone was laughing at me saying, yeah, it's just like Bitcoin. It's another hype cycle, right? But that's underappreciating what just happened. And us looking out here and thinking about the future of medicine, of healthcare, of taking care of people, have to wonder, who's going to lead this revolution upwards?
He is.
It's going to be her generation, right?
Yeah.
No, it's actually going to be our generation. Yeah. And they'll be heirs to what we do over the next 2-3 years.
Or 2-3 weeks, apparently.
Yeah, it's crazy, right? And
yeah.
I think that big tech is going to try to play a huge role in riding this. And if we as a profession don't start exerting a little bit of leadership and forward thinking in what we want these AI tools to do, how we want them to assist and scale us in doing the work that we do, it's going to be interesting as medicine gets disrupted. We're underserving the population. It costs too much, the outcomes kind of suck, and the average doctor is burnt out. That's a recipe for a profession that's on the verge of getting, I won't say the word, but it's bad. So there's a way that we can take back our futures and our fate. Cheng and I had this concept that we're literally amongst the last generation of physicians that will be practicing as physicians have for the last several hundred years.
Yeah, without AI. Yeah.
Yeah. But this is something to think about.